Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's funded in part by a grant from the Iowa Oncology Society. And this evening, we're going to talk about radiation oncology. And my guest tonight is Dr. Truston Bodine. Welcome, Truston.
Yeah, happy to be here.
So Truston is an MD PhD. We'll talk about what that means. Grew up in Utah. Went to medical school and got a combined MD PhD in Houston, and then did his residency in radiation oncology at KU Medical Center in Kansas City, and just joined us this year at MercyOne Cancer Center.
Yeah.
So welcome.
Yeah, it's been good to be here.
So tell us a bit about, so I'm really interested in the MD PhD. So as if getting an MD isn't tough enough, or getting a PhD isn't tough enough. At what point in your education did you think about this dual degree of being both a scientist and a clinician?
Yeah, so I kind of have a non-traditional path to the MD PhD because I started as actually a straight PhD student. I started graduate school as pursuing my PhD, but I was in a PhD program that was specifically geared towards translating research from the bench to the bedside. So I actually had a PhD mentor and an MD mentor.
Gotcha. And that whole term, for people who don't know, translation and bench and bedside.
Yeah.
So traditionally, you think of a PhD scientist as kind of a laboratory bench where you're doing all sorts of experiments and concoctions and developing new drugs or new treatments. And translation is where you take kind of the science and adapt it to actually treating patients.
Exactly. And so that was one of the focus of my research program. And so after working with, both on the research side and then seeing the clinical side, I knew I wanted to have that clinical component as part of my career. And so I actually applied and kind of re-interviewed for the dual degree program and was able to transfer into the MD PhD program after 2 years of my graduate school.
Gotcha. So you went to high school in Utah,
Yep.
And then your undergrad was University of Utah.
Yep.
What was your major, your undergrad major?
Biology.
Okay.
So pretty standard for pre-medicine.
And then did you have a particular aspect of biology? So when you started applying for PhDs?
Not specifically. So my PhD program was called Translational Biology and Molecular Medicine. So it was, like I said, really geared towards moving things from the research realm into the clinic. But there was a wide variety of options I could choose from. Anything from like biochemistry to biomechanical engineering. I chose a lab that actually focused on antibiotic resistance in gram-negative bacteria, so E. coli. So very not cancer really, but that's what I was interested in at the time, and I had a great experience.
And then, so traditionally medical school is 4 years. Traditionally, if you were just going to do a PhD right out of college, it would probably be about a 5-year program.
There's quite a bit of variability in the biomedical sciences. I would say the average time for a PhD is probably more like 5 to 6 years. Would be my guess. When you do the dual degree, it's a little bit of an accelerated track just because your training is already pretty lengthy. And so most of the time you usually will finish in 7 to 8 years with the dual degree. So it's almost essentially double what you normally would for a traditional MD program.
Gotcha. So you were in Houston in your MD PhD for how many years?
8 years. Then I stayed for my first year of residency. I did my intern year there also.
Okay. And then shifted to Kansas, University of Kansas Medical Center.
Yep.
How did you happen to choose radiation oncology as the field of medicine that you wanted to specialize in?
Yeah, that's a good question. There's a lot of options to choose from and a lot of interesting things in medicine, but we had some really good alumni from my program in Houston that were radiation oncologists. One that actually had his research lab at my medical school at Baylor and then practiced at MD Anderson. And so I met with him and started learning more about the field and shadowed him in clinic. And I really fell in love. It's kind of a marrying of the things that I like. There's a lot of cool technology. I like working with cancer patients. So I get a lot of patient-facing time, which is something I really wanted as part of my career. And then there's a lot of research also. So it kind of fit checked all the boxes of what I was
Mhm.
looking for.
And in your residency program, doing research is part of many different radiation oncology residency
Yep.
programs. And coming into a residency already with an MD, PhD, did your residency have expectations of you? Did you have expectations of yourself to do to continue doing research while you were doing your residency?
Yeah, I mean, the main goal of residency is to learn the clinical side of things, and you want to come out and have the training and all the knowledge you need to be a good clinician. And but you're also thinking about, how can I help advance the field? How can I contribute? And so that's kind of, in radiation oncology, we're pretty lucky. Most programs have a built-in like dedicated time. Like my residency program had 7 months where that time I was out of clinic, and all my time was focused on research and developing a project that I could move forward.
And what was your research project during your radiation oncology residency?
Oh, so I mostly focused on head and neck cancer and looked at a variety of different topics, but one was kind of actually some very radiation oncology specific things, looking at various setups that we use in head and neck cancer patients and how reproducible they are on a daily basis, and how to maximize that reproducibility to better treat patients and make treatments more accurate.
Okay. So I usually think of when I'm explaining cancer treatment to people that we kind of have three general ways of treating cancer: surgery, medicine, and radiation. How would you describe in general, and then we'll get into specific, the role of radiation in general for treating cancer?
We play a lot of different roles. In some cancer types, we're the primary modality, where we're the curative treatment. In other cancer types, we kind of come in behind some of the other, either surgery or chemotherapy to help clean up and reduce the risk of cancer coming back. And so I think we have a variety of different roles depending on the situation where we're employing our treatment.
Mhm. So we were chatting a little bit. We're about 30 years apart in training. And so I'm a radiation oncologist who trained basically 30 years before you. In your training program, did you have the opportunity to see in follow-up patients that had been treated 30 years before or 50 years before?
Not as often.
Not as, yeah. It's when I trained at the University of California, San Francisco, and they had what they called the orphan clinic. And so, as you can probably relate, in an academic medical center, the staff are also professors, and
Yep.
so they kind of oversee the patient's treatment, but they're not the hands-on always. And so when a patient got done with treatment, if their attending wasn't doing follow-up clinic, they would be assigned the Friday follow-up.
Okay.
And the residents would take care of the follow-up. So
Interesting.
if they no longer had a attending that was still on staff. And so the great thing was that we got to see patients that were treated, maybe 20 years before us.
Yeah.
And as you know, the science, the killing effect of the radiation beam hasn't changed much in 100 years,
No.
but our ability to direct the beam and spare tissue has changed. And
Very
so
much.
the side effects have changed a lot. But being able to see some of the late side effects of some of the early forms of radiation can be very educational.
For sure. I mean, I definitely saw a few patients like that, but not very often. And usually it was in the circumstances where it had a recurrence or something else, or a different type of cancer usually. And so you'd kind of see some of those long-term side effects, but at the same time be addressing the current situation and how we can best help.
So talk to us a little bit about the various types of radiation that you use, internal, external, the various names and types of situations. And then maybe we'll talk about some of the more popular common cancers and how radiation is used.
So there's kind of broad strokes. We use external beam radiation, which is essentially radiation coming from an outside source directed at the tumor. And then on some more usually in the more procedural realm, we use internal radiation or brachytherapy, where we deliver radiation source. We put radiation sources directly or near the tumor to deliver a high dose of very tightly conformal radiation is what we call it, but it just means the radiation is able to be delivered really to right where we want it and without too much dose spraying out other places where we don't want it.
Gotcha. So the external radiation, the source of radiation is outside the body, and you have various techniques of focusing it, and the internal is you actually put radioactive sources up inside the body.
Yep, exactly.
Okay. What would be the situations in which you put radioactive sources into the body?
The ones where we see it most commonly is in the gynecologic cancers and sometimes in prostate cancer. Those are probably the two biggest ones. There are some other areas. I haven't done much of this. I know they'll do it sometimes for skin cancer where they actually put it directly on the skin. I haven't had that opportunity to do that before, but I know there's some clinics that do a lot of that. And then there's a few other circumstances where they use that also. But gynecologic and prostate are probably the biggest two.
And were you trained? Did you have a large gynecologic service? And were you also doing the prostate brachytherapy?
Yes, we did a lot of both, actually. We had a pretty good, a pretty robust service on both sides of both prostate. So there's two different ways you can do a prostate brachytherapy procedure. You can do it by implanting radioactive seeds directly into the prostate that stay there and never come out. Or you can use catheters that go into the prostate and you feed a radioactive source in, and then that later gets retracted. And we did both of those procedures at KU.
Okay.
And then on the gynecologic, it's more that technique where you place catheters or other devices in direct proximity to the tumor and feed a source in and then take it back out afterwards.
Let's go to the most common cancers that we see in the United States. So the most common cancer that we see in women in the United States is breast cancer, and the most common cancer we see in men in the United States is prostate cancer. Radiation has a very prominent role to play in both of those.
Yes.
So when we talk about breast cancer to begin with, how would you describe the role of radiation therapy in the management of breast cancer?
In breast cancer treatment, radiation is a prominent role in almost every woman that has breast conservation treatment as a surgical approach. So if they're not getting a mastectomy, they're almost always going to have some form of radiation as part of their treatment.
So a woman with breast cancer that has a lumpectomy,
Yep.
as opposed to removing the entire breast, almost always has radiation as part of their treatment.
Yeah, generally speaking. There's a few circumstances where we don't, but that's kind of the general approach.
And what's the logic? If the surgeon's already removed the lump of cancer, what's the need to give radiation in that situation?
Yeah. So we know from many studies that yes, the surgeons can take all the tumor that we can see out. They have good clear margins, meaning they don't see any tumor on the edges of the specimen that they take out. But there's still a decent chance that the tumor comes back on that same breast. And so we know that there's microscopic tumor cells left behind that the surgeon can't see or we can't see on imaging. And so the goal of radiation is to kind of clean up afterwards and get rid of all those microscopic tumor cells and reduce the risk of the cancer coming back.
Yeah. And typically, how many treatments would that be for a woman with had a lumpectomy, lymph nodes are not involved, and where you give radiation to the rest of the breast?
Yeah, usually it's 15 to 20 treatments.
Okay.
Is the kind of standard course. There are movements to shorten that, even to as few as 5 treatments. So it's continuing. It was used to be 25 to 30. Now it's 15 to 20, and there's a push. And sometimes even more frequently in Europe, they use just 5 treatments. So that's kind of been the trend that we've seen.
Yeah. So when I got out of training, I would say the standard was 33. That was the most the sort of the mean number.
Yep.
And that over the course of my career in radiation oncology, it kind of went from 33 down to about 16, so almost cut in half. But as you said, one of the real pushes in radiation oncology is to give a higher dose per day and fewer number of treatments to try to accomplish the same thing, but make it logistically easier for patients.
Exactly. Maintain the efficacy and have similar or better side effect profile, but make it more convenient for the patient.
Okay. Besides treating the intact breast for a woman who's had a lumpectomy, what are other roles for radiation therapy in breast cancer?
Yeah, we will sometimes offer radiation after a mastectomy if they have a higher risk tumor or more lymph node disease that warrants, that they have a higher risk of their cancer coming back. And so we will and many times offer radiation in those circumstances also.
And when somebody's had their breast removed, what's the target, the area of the body that you actually focus the radiation on?
Yeah, generally in those circumstances, you'll be treating the chest wall or the area where the breast used to lie, and the draining lymphatic areas. That's the most common treatment after a mastectomy.
Okay. And then how about the use of radiation therapy in patients that have stage 4 breast cancer?
This is an area of kind of active research. There's been a lot of studies looking at treatment of metastatic spots of cancer, especially in patients that have limited numbers of spots where the cancer has spread. In breast cancer, this has kind of had mixed results. Some of the more recent studies that have looked at targeting, all the cancer spots that we can see in women that had a low number of metastatic lesions didn't show a lot of benefit, actually.
Mm-hmm.
And I think that speaks to how good our systemic therapy options have gotten for breast cancer, because they have a lot of good systemic treatment options that are very effective at treating even metastatic breast
chemotherapy,
cancer,
and hormone therapy, and
immunotherapy,
HER2-targeted therapy, and immunotherapy.
Yep.
And then obviously there's the role of palliative radiation in patients with symptomatic metastatic disease.
Exactly. Yeah. So in patients that have more widespread metastatic disease, to help with pain or other symptoms, radiation is quite effective and very well tolerated.
So one of the big changes that I've seen in the last 40 years, I guess, I graduated from medical school 43 years ago. The surgical techniques have changed. So I remember very clearly the first time I saw a woman who came in and told me that she'd had bilateral mastectomy, and I examined her and she still had breasts. And she had what we call a bilateral nipple-sparing mastectomy, where the skin and the outside skin and the nipple stays in place, and the surgeon removes the breast tissue and places an implant. So huge change in the surgical management. What would you say, based on your experience and your knowledge, have been some of the significant changes in radiation techniques in breast cancer that we've seen over the past
breast
generation?
Cancer, breast cancer is an interesting disease site because we still use some of the older technologies a lot of the times, and we're able to get good dose delivery and good sparing of the normal tissues. Some of the biggest advances that we've seen is the ability to treat with a breath hold technique, which is a technique where we're able to have the patient take a deep breath in and really help expand their lungs out and move their heart away from where we're treating with the breast area, and really spare their heart and their lungs a lot better than we used to be able to, especially for left-sided breast cancer.
So the patient's laying on her back.
Yep, exactly.
And when she takes a deep breath, the chest expands and it moves the breast upward, but the heart stays where it's at.
Exactly.
So it gives you a bigger distance between the back edge of the breast and the front edge of the heart.
Exactly. Yeah, and we have fancy technology to track their breathing and treat only in those in the right positioning. So that's been a big advancement.
Yeah, I had a professor once who said the real the role of the radiation oncologist isn't so much to treat the tumors, to avoid the normal tissue. It's easy to treat the tumor, and you can give any tumor any dose you want.
True.
But to give the tumor enough dose but spare the normal tissue, that's where the ingenuity, creativity, novel approaches of being very precise and accurate come into play.
Yeah, exactly. And that's where a lot of the research is focused on, is doing exactly that.
Yeah. And even you mentioning the heart, when we first started doing radiation to the intact breast in women who've had a lumpectomy, we're talking about 50 years ago, we didn't have precise imaging. And so in order to make sure you didn't miss any of the breast tissue, you just made the field bigger. But what ended up happening, especially on left breast cancers because the heart is on the left side. By making the field bigger, not missing a single bit of the breast, you ended up giving the left ventricle and the coronary arteries some radiation. And lo and behold, following those patients for decades, we found out that that type of radiation increased the risk of coronary artery disease from the radiation. So sparing the normal tissue is an important thing.
Yeah, for sure. And yeah, I trained in the image guided era, but that's been a huge game changer in our field, is having image to guide our treatment.
Yeah. So back then, you just designed the treatment based on, well, okay, here's this edge of the breast, this edge of the breast, this edge. And then to make sure you don't miss anything, you add another couple centimeters in every direction.
Yep.
And you come in from an angle, you can see you're treating the entire breast, but you have no idea how much of
What's
the
underneath.
heart was actually getting treated as well.
Yeah.
Yeah. Anything more you want to add about the use of radiation therapy for breast cancer? What about some of the techniques that put radiation devices inside the breast?
Yeah, there are a few centers that still do what the brachytherapy procedures for breast cancer, where they place a device at the time of surgery, where you can deliver doses of radiation intermittently, afterwards, and then remove that device. There also are still some centers will do what's called IOR2, or intraoperative radiotherapy, where they actually deliver a superficial dose of radiation directly into the lumpectomy cavity as part of the surgical procedure.
So you take the radiation machine into the operating room.
Yep.
So the patient's under general anesthesia. The surgeon removes the tumor, and while the incision is still open, the radiation doc puts a radiation delivery device into the breast.
Yep.
And gives the radiation
directly there. Yeah. The caveat to that is sometimes they find things on the surgery that warrant additional radiation, but sometimes they don't, and that can be the whole treatment that they require.
So obviously the advantage is that you might get the radiation over and done with at the same time as the surgery, same day as the surgery.
And you won't remember it because you're asleep.
Yeah. And in that case, you do it as a single dose of radiation.
Exactly. Yeah. Exactly.
Let's shift to the most common form of cancer in men, prostate cancer.
Yes.
And what are the treatment options in, let's say, we'll say early stage prostate cancer, which we'll define as prostate cancer where the cancer cells, as the best we can tell, are just within the prostate gland, haven't spread outside the prostate gland. What are the various treatment options for gentlemen with organ-confined prostate cancer?
Yeah, so there's probably three main categories you could divide up their options into. One is observation or active surveillance. So not any active treatment towards their cancer, because prostate cancer is one of the few that we know is a slow-moving cancer, and in the appropriate situations, that may be the best option. The other is surgery. They can have their prostate removed, have the prostatectomy. And the third is radiation. And there's a lot of study looking at radiation versus surgery, benefits, risks, versus, different side effect profiles. And from an oncologic outcome standpoint, they're essentially equivalent. So they're both equal options for patients that are looking at getting their prostate cancer treated.
And if the patient opts to have radiation, what are the various ways in which you could administer radiation to cure their prostate cancer?
Yeah, so this is one of the realms where you have internal radiation techniques you can employ, both as a treatment by itself, so no need for additional treatment. And in more high-risk patients, you can actually use that as a way to deliver an extra higher dose to the prostate to reduce the risk of it coming back. And then there's a lot of external beam radiation techniques too, some that last, as many as, if you're going back farther, as many as 8 weeks, 40 treatments or so. So what we most commonly employ now is about 5.5 weeks, 4 to 5.5 weeks, or even very stereotactic techniques where you're still using external beam radiation, so an external source, but you're delivering a much higher dose in a much shorter number of treatments, usually 5 treatments.
Right. So you can actually do the whole course of treatment in 5 treatments.
Exactly.
So I know you do that, and the technique that you use here at MercyOne Des Moines is a cyberknife stereotactic radiation. And What are the advantages of doing all of the course of treatment in 5 treatments as opposed to 43 treatments or 28 treatments?
Yeah, the biggest advantage is convenience. I mean, 5 treatments is just a lot easier for the patient to do. Um, and when they've done a lot of studies looking at the efficacy of this, and there's some biological benefits too of giving a higher dose per treatment in its effectiveness actually killing the prostate cancer cells, because it's kind of got a unique biology for cancer. And so there's like a biological advantage to doing it shorter. And then it's just a big convenience factor for the patient that it's just so much easier than, 5 treatments. Almost anyone can do that, especially if patients coming from really far away, in which we see a lot of patients here in Des Moines that come from many of towns, multiple hours away.
Or they're worried about getting the corn planted or the beans picked. That even though a once a day treatment for 6 weeks, it's only 10 minutes a day. But if you live an hour away and you need to be in the field, it can be 2.5 hours out of a working day.
Exactly.
So 5 treatments makes it much more convenient. When you're designing radiation treatment for prostate cancer, what are the organs, the normal tissue that you're concerned about, that if you treat too big of an area, you might cause damage to surrounding normal organs? What are you concerned about when you're treating a prostate?
Yeah, the biggest 2 things that you're concerned about is the bladder, which sits right above the prostate, and the rectum, which is right behind it. And so we use various techniques to try to protect those organs and minimize the dose there. And there's other procedures that, there's hydrogels that you can actually place that go in between the rectum and the prostate that actually create space there temporarily and help reduce the radiation doses to the rectum, and therefore reduce rectal side effects from the radiation.
And you mentioned that prostate cancer is one of the types of cancer where internal radiation can be used. Maybe describe some of those procedures where you actually put radioactive sources up inside the prostate to deliver the radiation kind of from the inside out.
Yeah, exactly. So these are pretty similar to how a prostate biopsy is done. So we'll use an ultrasound inside the rectum to visualize the prostate as we're doing the procedure. And then we actually place needles through the skin, through the perineum, the skin that's in between the scrotum and the anus. And that way we gain access to the prostate. And through those needles, they're like hollow channels. That way we're either able to deliver the radiation that's on the end of a wire on that source and then take it back out, or drop those seeds in and then remove the needles afterwards.
And those seeds, and typically it can be maybe 100 seeds that you diffusely, or not diffusely, that you systematically
kind of spread throughout the prostate. Yep. Yeah, the number of seeds that you need depends on the size of the prostate, essentially. So it can go, for anywhere from very low numbers up to,
And is that a technique you did in training?
The
low dose seeds. So approximately what would be an average number of seeds you would do?
I'd say mostly around 60 to 70.
Okay.
Probably. If they have a very large prostate, more. Very small, because sometimes it's really, the prostates have a wide variety of sizes, just like all of our other organs in our body. So, but yeah, probably on average, 40 to 70 is probably the range you'd most commonly see.
One of the difficult things with a slow growing tumor is it takes years and years of follow-up to actually know, is this patient cured of prostate cancer or not?
Yep.
And also side effects. Talk a little bit about the difference between acute side effects and late side effects.
Yeah. So the acute side effects are things we see during treatment and kind of the period of time shortly thereafter. And most of those, for most of our treatments in prostate cancer and breast cancer, other cancers, largely resolve. The radiation effects kind of wear off, and they start feeling better. But there are some long-term side effects that can be permanent, be it in the prostate realm where we're talking about now. You can have some permanent changes in your bowel function or permanent changes in your bladder function. Usually those aren't severe, but you may notice some subtle differences long-term. And then there's other more serious side effects long-term that you need to look out for, like blood in the stool, blood in the urine, things like that, that the radiation can predispose you to.
And then there's late side effects that don't even show up until years later.
Yep.
I mean, one would be erectile dysfunction, that a gentleman who has normal ability to get erections can go through the radiation without any impact on it, but maybe 5 years later, as the scar tissue starts to develop, up to 50% of men might get erectile dysfunction as a very delayed
late side effect. Yeah.
Yeah.
So that's why we continue to follow these patients and watch them closely, so we can continue to help them with any long-term or late side effects and continue to monitor their prostate cancer.
So one of the fields of research that we're learning about, and not just prostate cancer, but in other types of cancer, is this whole field, and it's a weird word that we're just getting to know, and it's called theragnostics, which is a word that combines therapy with diagnostic, and it's the use of radioactive isotopes that you administer intravenously. So you want to describe a little bit about the FDA approved treatment that goes by the brand name Pluvicto. That's a radioactive isotope you give intravenously for metastatic prostate cancer. How does that work? And
this is an area that's really been advancing, and a very exciting area to kind of watch progress. It's usually some sort of targeted molecule that gets taken up by the cancer cell that has a radioactive isotope hooked up to it, essentially. So it's a way of targeting your radiation, but on a molecular level. So it's kind of a molecular targeted radiation, which is something we can't do even with internal radiation or any of the external beam radiation techniques we have. So in prostate cancer, the Pluvicto that you're alluding to is a PSMA molecule. So a PSA molecule that gets taken up by the prostate cancer cells, has a lutetium radioactive isotope linked up to it. And so it gets taken up by the cells, and they deliver that little localized radiation dose and kill the cancer cells that way.
Yeah, so you rely on that PSA molecule to actually carry the little the radioactive isotope, the little nuclear bomb. I probably shouldn't say that, but they take it right to the cell.
Exactly.
Yeah.
So you don't have to deliver high doses when you're inside the cell.
Yeah. And it's called theragnostic because the diagnostic version is you take that same PSMA molecule, but instead of attaching a cancer-killing lutetium isotope to it, you attach a little wimpy gallium isotope to it. You give the intravenous injection, and you put the person through a PET scanner, and you use the gallium to find where the cancer cells are. Then once you've found that the PSMA can find the cancer cells, then the treatment is to take that same PSMA molecule, but instead of attaching a little wimpy gallium isotope to it, you attach a lutetium-177 isotope to it and give it to the patient, and the PSMA carries the lutetium to the cancer cell.
Exactly.
Was that a treatment that you were doing at KU when you were there?
We had just started administering that in our clinics. It's at the time, at least 6 or 8 months to a year ago, there was only one site in the world that was making this drug, and so there was a huge backlog. So a lot of our patients we had on a waiting list to get it, and so they were just waiting, and we were hopefully, anxiously awaiting the arrival of the drug so we could treat our patients.
And we should say that this is for stage 4, so patients with metastatic, incurable cancer. And although the treatment is exciting, it's not a curative form of treatment.
No, not yet. But there's going to be a lot more of this moving forward in the future, both in prostate cancer and a lot of other cancers.
Yeah, I mean, we're already seeing it in neuroendocrine cancer. There's an FDA approved, but I understand that the research is out there for using it in if you can find a carrier molecule that will go to the cancer cell, it could theoretically be used in any type of cancer.
Exactly. I mean, it's been a long-standing tenet of thyroid cancer treatment for many years with iodine. So.
Yeah, radioactive iodine. So you get to choose next. What's the cancer site that you want to talk about next? The role of radiation therapy and the management of what type of cancer?
I don't know. I'd say probably one of the next most common one we see is probably lung cancer.
Yep. So overall, lung cancer is the cancer that causes the most deaths
Yep.
in men and in women and in the United States. So, how would you describe the role of radiation therapy in lung cancer? What patients with lung cancer get radiation as opposed to surgery or with chemotherapy? It's an evolving field, but
Yeah.
how would you just lay out the role
Yeah.
of radiation in the management of lung cancer?
Radiation has a very big role in the treatment of both early stage, late stage, and even metastatic lung cancer. So in the early stage, we often will employ that cyberknife or stereotactic radiation to use pinpoint radiation to treat the tumor, especially in patients that are eligible or not looking for surgical treatment. In the late stage, we are the curative modality combined with chemotherapy to treat their lung cancer. And then in kind of the more metastatic or stage 4, if they have limited sites of disease, like I was alluding to earlier, there's a lot of studies showing that we can really improve outcomes by targeting those individual sites with radiation treatments.
Mm-hmm. And then obviously there's also the role of palliation of symptomatic metastatic disease, probably very common. I mean, stage 4 lung cancer is very common. With breast cancer and prostate cancer, it's really common to have early stage disease. Before we started doing screening for lung cancer, it wasn't so common to diagnose a stage 1 lung cancer.
Yeah, true. But yeah, in all cancer types, if the cancer is spread and is causing local pain or symptoms, there's a big role of radiation to help with those symptoms.
Like bone metastases or brain metastases.
Exactly.
You mentioned that part of your research while you were going through your residency was head and neck cancer.
Mm-hmm.
And we just had our annual cancer report, Cancer in Iowa. Iowa leads the nation in the increasing incidence of head and neck cancer, more than any other state. And as you know, in this day and age, one of the most common risk factors in head and neck cancer is the HPV virus. So talk a little bit about HPV virus and how that leads to the development of cancer of the oral pharynx, back where the tonsils and base of tongue are.
Yeah. So HPV is a virus we've known about for a long time, human papillomavirus. So it is associated with various other cancer types. The other main one that we know and kind of check for this for HPV for is in cervical cancer. So it's one of the
cervical meaning cancer of the cervix.
Of the cervix.
Yep.
It's one of the few ways that we can actually prevent cancer before it happens. We have a vaccine for the human papillomavirus that could prevent a lot of these head and neck cancers and cervical cancers from even developing in the first place. That's a more recent development, so we'll have to see kind of epidemiologically how that affects the incidence of these cancers long term. Hopefully it drops it significantly.
So back when I was in residency, we didn't know the relationship between HPV and oral pharynx cancer. We certainly were aware of the relationship with cervix cancer. That's been known for decades. And the other two most common risk factors for throat cancer are cigarette smoking and alcohol consumption. So back when I was in training, most of the time, if you saw someone with a cancer in the back of the throat, it was someone 60 or older who had a long smoking history and alcohol consumption. And now we're seeing it in much younger patients who have never smoked and don't consume a lot of alcohol. And fortunately, we're able to tell from a biopsy whether it was actually caused by the HPV.
Exactly. And the good news is those HPV-related tumors tend to have better response to treatment and better long-term prognosis for the patients. So it's unfortunate that we're seeing it in younger patients that don't have the traditional risk factors. The good thing is they're very treatable, and we're seeing very good outcomes with definitive treatments.
And describe a little bit what the patient would go through for treatment of HPV-mediated oral pharynx cancer.
Yeah. So there's a couple of different pathways you can go down. Usually involves meeting with a medical oncologist, a radiation oncologist, and a head and neck surgeon, because those are the kind of the three main modalities we use for the treatment of head and neck cancers. Most of the time it involves, most of the time these things present with a lump in the neck that doesn't go away. It's usually not having pain there. They just notice that, I didn't have this there before. They usually get antibiotics before it doesn't go away, and then they end up getting a biopsy, and that leads to kind of the diagnosis and workup.
And that lump they feel isn't actually the primary cancer.
No,
that's the cancer that's already gone to a lymph node.
That spread from the primary site.
And usually have a tiny cancer in the back of the throat, but a big lymph node.
Exactly. And that's something that we see more commonly with HPV mediated tumors, that the primary tumor that started in the tonsil or the base of the tongue is very small, so you don't really notice many side effects from it, but you do notice the lymph node spread because it's more superficial. You can feel it, and that leads to earlier diagnosis, which is good.
And so let's say patient's going to get a combination of chemotherapy and radiation. How long does that typically take? What are some of the acute side effects that they experience while they're going through the radiation and chemotherapy?
Usually the treatment duration is longer for head and neck cancer, usually 6.5 to 7 weeks, often with concurrent radiation.
And that's once a day, Monday through Friday.
Once a day, Monday through Friday, usually with chemotherapy combined with radiation. And that chemotherapy is usually once every 3 weeks or sometimes once a week, depending on the situation. But yeah, so you're looking at a daily treatment for about 6.5, 7 weeks with radiation to the head and so the primary area where the tumor started and the lymph nodes, often on both sides of the neck, because even if you don't have an obvious lymph node on the other side, these tumors, there's a lot of lymphatic drainage in the head and neck area, and so you usually will give a lower dose on the other side to kill any possible microscopic diseases that could be there that we can't see.
So it's a fairly big area you're treating.
It is a big area.
So the side effects can be pretty significant during those 7 weeks of chemoradiation.
Yeah, this is probably the area where we see some of the most pronounced side effects with radiation treatment of any site that we treat. Just because, like you said, there's a lot of important real estate in this area. Your mouth, you have your swallowing tubes, your esophagus, your voice box. All those things are all in close proximity. Salivary glands. And so the things, and the skin, because we're treating the neck that's close to the lymph nodes that are close to the surface. So the things that we most often see is like a sunburn type of reaction on the skin, dry mouth, taste changes, sores in the mouth, sometimes some voice changes. And some of those can be pretty profound. And actually the mouth sores can be quite painful. So.
And swallowing. So when things don't taste good, you have a dry mouth and a sore throat, and you can't swallow very well, it impacts your nutrition.
Yeah. And so we have a nutritionist on staff that works really closely with all of our patients that are undergoing head and neck cancer treatment. And often these patients will require a feeding tube to help get them through the treatments.
And it's also one of the areas where the delayed or late side effects
are very pronounced.
Can be very pronounced.
Yeah. Some of that dry mouth will never go back to where it was. You'll recover some of it after treatment, but depending on where we have to treat and where your tumor was, you'll always be a little bit drier. And that has multiple effects on your long-term functioning, because saliva is important for a lot of things, but one of the things, it's important for taste. It's important for protection of your teeth. So this is something that often gets overlooked long-term, is that the patients, after they get cured of their head and neck cancer, need to have really good dentition and dental work. See their dentist very regularly, and sometimes we often will give them fluoride trays to protect their teeth because they're at permanent increased risk for cavities.
Because our normal saliva kills bacteria, and when you don't have the normal saliva, you can have more advanced decay of your teeth. And a swallowing dysfunction can be an issue that can lead to chronic aspiration.
Yeah, and that's something we always really look at when we're developing these treatment plans, is how can we minimize the dose of those swallowing muscles, still treat the tumor. That's always the delicate interplay that we're playing with as radiation oncologists, is we need to treat the tumor, but how can we reduce kind of the long-term toxicity? And when we cure this cancer, which is the goal.
Right, because it's highly curable.
It's very highly curable. How can we give them the best long-term functionality and eating outcomes and things? Because it's it's no fun to cure a cancer, but then be miserable, not being able to eat, not being able to taste your food, having recurrent pneumonias from aspiration. And so we do our best to kind of reduce those long-term side effects.
I think what we're going to do now, rather than going on to another type of cancer, we're going to open up to questions.
Sure.
We have a live studio audience here. We also have those of you watching us live stream. If you're watching us live stream and you have a question, you can just put the question in the comment section, and we'll open it up first to some questions for our folks that are here with us in the room.
I'll start. The cyber knife, which is that something you think you would eventually use for breast cancer on the left side, since it's probably the most precise?
Yeah, so there are some institutions that are looking at using CyberKnife, or more specifically stereotactic type of techniques, where you're not treating the entire breast area anymore, where you're treating just partial breast, essentially the area where the tumor was, with a safety margin around that. And that's usually done over the course of about 5 treatments also. So it's pretty similar to CyberKnife techniques. We haven't done it at our site, but there are some institutions where they're actually using the CyberKnife for that. There's some technicalities that you have to work through and kind of become experts in to do that safely and effectively, but it is something that they've been looking at.
Great. Thanks. Other questions?
The question that I have, because of the great advances that we've seen in radiation and chemotherapy, survivability rates are going up.
Yeah.
The incidences of some cancers are increasing, and that's very troubling, particularly in the state of Iowa. But the question that I have is, you still hear a lot from people that are so fearful that they want to have the breasts removed. They want to have the prostate taken out. And is there less of that now than there used to be? Because I still hear about it a lot. And do patients have to be counseled about that?
Yeah, I think you bring up a good point. I think that where we often see this is in breast cancer. And some of that is from kind of mainstream media sources where they've seen, movie stars or other famous people that have gotten mastectomies. And so they kind of get that as their frame of reference, and they come in thinking like, that's what I'm going to need. The surgeons are at the forefront of counseling the patients in this regard, that no, you don't actually have to have that large surgery with full removal of the breast. We can preserve your breast, still have you have a great cancer outcome. But there is a lot of kind of misconception and misinformation out there that you have to sometimes talk the patients through and educate them on.
And I would say that almost everyone knows somebody who's been treated for cancer.
Yeah.
And some of the older techniques for both radiation and some of the older techniques for chemotherapy could have lots of side effects. And so everyone sort of knows somebody who had an advanced cancer, had chemotherapy and radiation. They remember the side effects and the fact that the patient died anyway. And the idea of these nebulous, mysterious treatments of a chemical or of radiation with lots of side effects, as opposed to our concept, well, I know what surgery is. Surgery is they make an incision, they take the cancer out, it's gone. So it's simple for everyone to understand the concept of surgically removing a cancer. It's more complicated and confusing to understand this invisible radiation beam that can kill cancer cells but cause side effects. And the same with chemotherapy, and especially some of the older chemotherapy regimens that had horrible side effects. So I would say in general, more patients are afraid of kind of the unknown side effects of radiation, unknown to them, side effects of chemotherapy and radiation, and are a little bit more understanding of the concept of having something removed, whether it's your tonsils, your appendix, or a tumor.
I'm going to tag on to what George just asked, because I'm a breast cancer survivor. And that was the thing that came to my mind, was social media. And, in my brain was like, oh, then I should have the other removed. And when I came to see the oncologist, I ran into a woman who had cancer return. And she turned around and said it went to the other breast. And she had the other one removed. And she just gave me advice. If you got diagnosed, you might as well ask for both of them. I'm like, wait a minute, you know. And in talking to my surgeon and trusting all my oncologists in the team, I'm also a type 2 diabetic. So it was a really high risk to try to do a mastectomy. Yeah. And said we could do a lumpectomy. I had to work my butt off here at the fitness center to keep control because they gave me two types of chemo and one type of steroids. So, and they had to increase it because it went to 3 centimeters.
Yeah.
I was like, oh boy. So I totally get that. And it's different for everyone.
Yeah.
And the fear of, I'm going to lose my hair is the only thing that I'm hearing women worry about. I said it grows back. I mean, my root hair came back. I'm okay with it. I'm embracing it. But that's just a temporary thing. Yes, there are side effects, but they have made such a progress in it that even during the treatment, it wasn't as bad as what I've heard from other people's past experience. So, but how do you counsel people about when they're concerned that, yeah, I had it removed on one breast, but I'm concerned about the other? What do you say to that patient and you know, helping them out with that?
Yeah. And some of those are pretty difficult situations because they come in with different preconceived notions and experiences, people they've known, like Dr. Deming was alluding to, that they've talked to. And so you have to do your best to kind of educate them on, you know, the outcomes, the potential side effects with both treatments, and the advantages and disadvantages. But at the same time, you can counsel them to speak to people like you that have been through it and had a different experience maybe than the person had more on the extreme where they've had both breasts removed and had a bad experience. But I think the sources of where they're getting the information can be deceiving sometimes. And so you do your best to counsel them and teach them what we know from the studies and what's the best options for them. But ultimately, it's the patient's decision, and we try to respect that autonomy. But it can be difficult at times to come to a consensus and really help them kind of see the full picture.
And I would say one of the advantages we have now is there are so many studies that give us the ability to really put into understandable term what is the risk that you're going to have the cancer be in your other breast. Yes, I mean, theoretically, anything is possible. But just like we learned to drive on the interstate, the first time you're driving on the interstate at 65 miles an hour, and I mean, you are afraid there's going to be an accident. And yes, there's going to be, 300 fatalities in Iowa. But when you put it into context of how many people are driving how many miles throughout the course of the year, and you have 300 people that die, yes, you could die driving on the interstate, but it's highly unlikely. And in some cases, the risk of a cancer coming back, we can put it in more understandable terms. It's yes, you may know somebody where the cancer came back in the other breast a year after they were treated, but let's look, you have stage 1, grade 1, estrogen receptor positive breast cancer in your right breast that is this size and the nodes are negative. When we look at all the women that have been treated with that stage of disease, the chances of having a breast cancer come back in the other breast is, less than 3%. So being able to validate one's concerns, but then tell them, let's just look at the data and see what if you just have a lumpectomy, radiation, and anti-estrogen treatment, what's the likelihood that you will be cured of your cancer without it recurring? And most of the times, those statistics are very comforting to patients.
For sure. Mm-hmm. And in breast cancer, we have a lot of good statistics. And some of the other lesser studied cancers, we don't have that much real granular data where you can't get them the exact percentages and stuff, and that makes it more difficult. But in the breast cancer, prostate cancer, we have a lot of good data to really guide them.
So, George, we have opportunity for one more question. Do we have any questions from? Okay, here we go.
I'm interested in the HPV virus and the fact that it seems to be increasing the amount of cancer, in the head and neck. Is there any statistics or any knowledge as to why that is happening? Is there changes in the virus, or is there changes in our physical beings? I'm just curious if there's any information on that.
I don't think there's been changes in the viruses that I know of. I think it's more changes in our activities and our sexual practices. With the increase in oral sex, that it leads to increased exposure of HPV virus to the oral cavity and oral pharynx, where we see these cancers. And I think that's what's led to a lot of the increase in incidence of HPV mediated. Plus, we have much better tests to look for it. So it may have been occurring all along. We just didn't notice it, as we didn't know because we weren't testing for it.
Yeah. So there are 6 cancers that are caused by HPV. In women, cervix is the most common, but the other cancers that women can get that can be caused by HPV virus are vaginal cancer, vulvar cancer, so that's the skin on the outside of the pelvis, and cancer of the anus. In men, and women can also get oral pharynx cancer, but ironically, the oral pharynx cancer caused by HPV is much more common in men than in women. And then in men, the oral pharynx cancer, cancer of the anus, and also cancer of the penis. But ironically, in women, it's cancer of the cervix, but very unlikely that a man will get an HPV cancer of the penis. But in the men, it's the cancer of the oral pharynx that's the most common. Yeah. So those are the 6 different cancers caused by HPV. And HPV has been around for a long, long time. The HPV is not a venereal disease that causes a disease, but viruses, unlike bacteria, actually incorporate their genetic material into the genetic material of a normal cell of the human being. So they can't exist without a live cell. And almost all the time that people get HPV in their system, it does not cause cancer. Because once one gets to the age of having had sexual relationships, you've probably been exposed to the HPV, but only a small minority of those patients actually get a cancer because of the HPV. And as Dr. Bodine said, we now have, which didn't exist when I was growing up, an HPV vaccine that is best given at ages of about 11 to 13 that can prevent those 6 different types of HPV-mediated cancer. So we don't think that the virus has changed in a way. We do think it is more ubiquitous, it's more ever-present, that sexual intercourse at younger ages and more frequently, and the changes of practices to just genital to more oral genital has definitely been what's increased the increase in oral pharynx cancer caused by HPV. And with that, we're going to have to bring it to a conclusion. We could probably go on for another couple hours. We're going to have you back again because we only covered, 3 different cancer sites. So our guest tonight has been Dr. Truston Bodine, MD, PhD, radiation oncologist to the MercyOne Cancer Center. Thank you for being with us.
Thank you for inviting me. It was a pleasure to be here.
And thank all of you. If you know someone that would benefit by watching this program, it's going to be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the MercyOne Cancer Center website. Please join us again next week. Thanks for coming.